In this presentation, the Lapidus procedure, a corrective osteotomy and fusion of the tarso-metatarsal joint, will be performed to correct a hallux valgus deformity. A surgical marker is used to mark the periosteum as well as the joint capsule. This makes it easier to find and close over the fusion site. Closure of the periosteum joint capsule layer decreases the incidence of non-union. The 15-blade scalpel is used to incise straight down to bone along the metatarsal, over the joint, and onto the medial cuneiform. The flat of the blade is then used in a filleting motion as a sort of periosteal elevator. In older patients, it can be a little difficult finding and saving this layer, but the extra effort can help with closure and healing of the fusion site. Starting from the joint level and continuing either proximally or distally with the same filleting motion, the periosteum is carefully preserved as best as can be. Sometimes a little bit of cortex is taken up, which is acceptable because it helps with the healing when it is laid back down. Here the periosteal layer, the base of the first metatarsal, the TMT joint, and the medial cuneiform can be seen. At this point, the pocket hole is made 2 centimeters above the joint to ensure the screw has enough leverage to capture the base of the first metatarsal and go into the cuneiform. One common mistake that is made in this procedure is inserting the screws too close to the joint. The retractors are repositioned, and the layer that was marked in purple is retracted in order to protect it from the burr. The pocket hole is burred using the electric pen drive. The pocket hole should have a near vertical wall proximally and a slope going distally, creating a ramp for the screw to slide down before engaging the base of the first metatarsal and thus helping to prevent cortical breakoff. At this point, attention is redirected to the distal part of the incision. The retractors are repositioned. The scalpel is brought down along the lateral head of the metatarsal. The retractors are repositioned a little deeper. A formal release of the adductor is not performed, but the capsule is released in the direction of its fibers. The goal is to release the sesamoids so that the metatarsal head can be returned over them. Switching to the medial incision, the skin incision is made centered over the first MTP joint. An incision is made along the periosteum, continuing along the joint capsule and then up the metatarsal shaft. Starting in the joint and coming around, the periosteum with the flexor complex is lifted in one layer. The retractors are repositioned. The soft tissue is lifted over the top of the metatarsal head to allow the metatarsal head to re-center. The soft tissue or bursa that might be there is cleared off. Although there are times when the medial eminence is significant, frequently the medial eminence is a product of malrotation, so the basal part of the bone is addressed before the medial eminence is cut. By rotating the metatarsal head back into proper alignment, it can be that the so-called medial eminence disappears. If a large medial eminence remains after the osteotomy is closed, it is possible to return and shave it right before the capsular plication is done. The EHL and EHB are retracted to expose the TMT joint and the pocket hole. In order to increase the leverage of the screw head and reduce the incidence of cortical breakoff, a dorsal pocket hole will be made in the base of the first metatarsal, 2 centimeters distal to the joint. The depth gauge is used to measure a distance 2 centimeters from the joint, which is then marked on the bone. The pocket hole will be made with the round burr attached to the colibri 2. To shape the pocket hole, a vertical wall is made, followed by a ramp coming up distally. When burring, care is taken to maintain the 2 centimeters distance from the TMT joint. To do this, burring should be directed away from the joint. Once the pocket hole has been made, there is a bit of a ramp that can be seen going from left to right. The purpose of this is to allow the screw head to engage without cortical breakoff. The pocket hole is burred before sawing the osteotomy, because the ligaments are all still attached and the structures are stable. This would not be the case if the osteotomy cuts were made first. A straight saw can now be used to remove the medial eminence. The depth of the joint and cut is approximately 3 centimeters, and the saw blade should be that long. The cut should not be made on the head side of the sulcus. The sulcus is located here. If the cut is made on the head side, it can be destabilized and go into hallux varus, which is the opposite deformity. So the cut is made on the outside of the sulcus, with the blade angled as shown here. If the cut is made as shown here, the sesamoid can be cut and destabilized. Care is taken to maintain the sesamoid tracking area, so if this is neutral, the cut is directed slightly this way. Clinically, the resection is rarely this large. It is generally smaller because the deformity is not that great. The cancellous surface of the resected bone can be seen here. This fragment can be a good source of bone graft for later use. Clinically, a knife handle is used to reach underneath and release the sesamoids from the underside of the first metatarsal, as there are adhesions there. The goal of the surgery is to push the metatarsal head back over the sesamoids, or the flexor complex, which can't be done unless they are released. The osteotomy will now be made at the TMT joint. The first cut on the base of the first metatarsal is a flat cut that does not provide much correction. Sawing too much on the first metatarsal can cut and release the peroneus longus tendon, which attaches to the lateral base of the first metatarsal. The saw is used to begin the osteotomy cut on the first metatarsal. The cut is completed with the hammer and chisel. The second cut, which will be made on the medial cuneiform, is lateral and plantar-based to correct the intermetatarsal angle. Clinically, the amount of correction can be anticipated by measuring the preoperative X-ray of the intermetatarsal angle and then transposing that. The osteotomy cut is started with the saw. To correct the IM angle, the goal is to have two flat surfaces that are perpendicular to the axis. A flat cut is made here perpendicular to this axis, and another here perpendicular to this axis. As before, the cut can be completed with the hammer and chisel. The TMT is carefully distracted with the bone spreader. A pituitary rongeur can be used to remove the waste of the cut. It is important to clean out the very bottom of the cut because sometimes there is a little bit of bone that can lead to dorsiflexion, resulting in second metatarsal overload. Once all the pieces of bone have been removed with the pituitary or small rongeur, it can be seen that the osteotomy closes very nicely and plantar flexes slightly. This slight plantar flexion protects the second metatarsal and prevents second metatarsal overload. The rotation of the toe and metatarsal are checked, and then the bones are seated. It may be preferable for the metatarsal to be slightly displaced inferiorly. The reduction can be provisionally stabilized with a K-wire, which is angled during insertion as shown here. Care is taken to ensure that the trajectory of the K-wire does not interfere with the planned trajectory of the screws. A second K-wire can be inserted for additional provisional stabilization. In a clinical situation, the joint surfaces, medial base of the second metatarsal, and lateral area of the first metatarsal are drilled with a 2 mm wire to prepare them for fusion. This helps to create an intermetatarsal fusion, which, when combined with the TMT fusion, helps further stabilize this region. The next step will be to fix the TMT joint with a self-tapping 4.0 mm cortex screw inserted as a lag screw. This screw has a 4.0 mm thread diameter and a 2.9 mm core diameter. It is important to note that the bone is very soft. It is not really hard cortical bone, but rather soft cancellous bone, more like a shell with a soft interior. The thread hole will be drilled using a 2.5 mm drill bit through the 2.9 mm sleeve. Since the thread hole is smaller than the core diameter of the screw will radially push the cancellous bone outward. This differs from standard AO technique, in which the thread hole is drilled to the core diameter of the screw. Starting at the pocket hole that was prepared earlier, the 4.0 mm glide hole will be drilled through the 4.0 end of the double drill guide to the base of the first TMT joint. In the top view, the drill is aimed from lateral to medial, and in the side view, the drill is aimed plantar. The drill is aimed approximately in line with the second toe. When drilling, it is important that the drill is kept within the pocket hole and kept from skating toward the joint. The 4.0 mm drill bit is removed. The 2.5 mm drill bit is slid through the 2.9 end of the double drill guide into the hole, and the drill guide is carefully wriggled into the 4.0 mm hole in order to prevent any cortical break-off. The 2.5 mm thread hole is drilled from the base of the first TMT joint to the plantar medial corner of the base of the medial cuneiform. After the hole has been drilled, the double drill guide is wriggled out of the 4.0 mm hole. The depth is measured with the depth gauge. In this case, the length is 44 mm. The appropriate length self-tapping 4.0 mm cortex screw is inserted. The screwdriver is kept in place to help direct the insertion of the second screw. The second screw is aimed plantar and slightly lateral to the first screw. The 4.0 mm glide hole is drilled in the medial cuneiform through the 4.0 end of the double drill guide. The 2.5 mm drill bit is slid through the 2.9 end of the double drill guide. The end of the drill guide is wriggled into the 4.0 mm hole to guide the insertion of the 2.5 mm drill bit. The 2.5 mm thread hole is drilled. The 2.9 mm end of the double drill guide is wriggled out of the 4.0 mm hole. The depth is measured with the depth gauge. In this case, the depth is 40 mm. As this is a lag screw, it can be seen that the screw is pushed through the glide hole before engaging the thread hole. The correction of the IM angle can be seen here. To facilitate fusion, supplemental bone graft will now be added. The burr is used to make the shear strain relief troughs along the TMT fusion. The first trough is prepared dorsal, The second trough is prepared dorsomedial. The simulated bone graft is inserted into the troughs and then molded into place with the fingers. Normally, with this construct, the patient would be non-weight bearing for 6 weeks. To encourage more reliable healing and earlier weight bearing, a plate will be added. If there is too much of a prominence of the medial cuneiform, then the prominence can be shaved down with the saw in order to create a flat surface for the plate. At this point, one of the participants can hold the plate in place. The plate is centered over the osteotomy with 3 holes distal and 3 holes proximal. The plate will be provisionally secured with compression wires inserted through both cortices. The first compression wire is inserted through the compression wire hole on the distal side of the osteotomy. To allow compression, the second compression wire is inserted at the proximal end of the compression slot. The compression forceps are attached by placing the arms around the compression wire spheres. Compression is applied by squeezing the handles. Compression is possible because the 2 screws that were inserted to fix the osteotomy were inserted as lag screws. The plate will be fixed with screws that are inserted using either a predefined nominal angle or variable angle. Depending on how the screws will be inserted, either a coaxial or variable angle drill guide may be utilized with the 2.0 mm drill bit to prepare the screw holes for the locking screws. The conical variable angle drill guide allows for 15 degrees off of center in any direction. To address any intertarsal instability, the first screw hole is drilled using the conical variable end of the VA LCP drill sleeve 2.7 to direct the 2.0 mm drill bit toward the medial cuneiform. The depth gauge shows the trajectory of the screw and then is used to determine the appropriate length screw. In this case, a length of 26 mm is measured. A self-tapping 2.7 mm VA locking screw is inserted using the star drive screwdriver shaft and torque limiting handle. The second screw hole is drilled nominally using the coaxial end of the VA LCP drill sleeve 2.7 to direct the 2.0 mm drill bit. The line on the drill bit indicates the depth of the screw. Here, a 16 mm screw is chosen. A self-tapping 2.7 mm VA locking screw is inserted using the star drive screwdriver shaft and torque limiting handle. The compression forceps are removed. The compression wires are removed. The third screw hole is drilled using the variable end of the VA LCP drill sleeve 2.7 to direct the 2.0 mm drill bit. One of the benefits of the variable angle is that screws can be aimed so as not to collide with other screws. The depth is measured and the screw is inserted. The remaining screw holes are drilled, measured and filled with 2.7 mm VA locking screws in the order shown here on the completed construct. In the post-operative AP, lateral and oblique X-rays of a clinical case, the trajectories of the screws and position of the plate can be seen. Post-operative care includes a plaster splint for 2 weeks, a controlled ankle motion boot with controlled range of motion but strict non-weight bearing for 6 to 12 weeks, progressive weight bearing with possible removal of hardware at 3 or more months, or allow hardware to remain in place as these are non-essential joints, and removal of K-wires if used after 6 to 8 weeks. You should now be able to describe the anatomy of hallux valgus deformities, including establishing the presence or absence of first-ray hypermobility, explain the Lapidus procedure for the correction of bunion deformities, recognize the indications, approach, details, and tips and tricks of a Lapidus procedure in order to gain the best possible outcome with deformity correction, assess the available options for managing the procedure, and define the post-operative regime.